Good evening, everybody. Thank you for joining us today. I appreciate your patience with us. Excuse any dog barking or children sounds. I am at home, like many of you, so I appreciate your understanding. Today, I am really pleased to have you join us. My name is Jamie Seward. I am an Associate Director of Affinity Engagement with the Johns Hopkins Office of Alumni Relations. And before I turn the program over to our program moderator, I encourage you to ask any questions you have by typing them in the Zoom Q&A in the bottom of your screen. We'll have time at the end of the program to answer those questions. I also want to share that the chat feature has been turned off for this program. It's now my pleasure to turn the program over to one of our most incredible engaged volunteers, Lorraine Hutzler. She's a great leader of our affinity, our healthcare affinity, alongside Tatiana Carret. Lorraine is the Associate Program Director for the Center of Quality and Patient Safety with NYU Langone Health. And she's also an alumna of the Krieger School of Arts and Sciences class of 2008. So we're so happy to have her here with us. And I will turn the program over to Lorraine. And if you're a speaker today, please feel free to turn on your camera and unmute yourself because we are here to hear you. Thank you so much.
Good evening, everybody, and thank you so much, Jamie. We have a wonderful panel in store for you tonight. We're going to discuss the economic impacts of COVID-19. If each of our panelists would kindly go ahead, introduce yourselves, tell us a little bit about your specialty, and maybe one brief insight about your thoughts on COVID and the economy, and we'll get started from there. So please go ahead. Thank you.
Okay. Jamie, I just want to say it's Kathleen Day. I'm getting the message. Zoom is telling me that you have to turn on my camera. It won't let me do it because you've stopped it.
I'm getting the same message.
Well, let me just fix
there
that.
We are. Through the magic of technology. I was going to say the magic of chemistry, but it's technology. So, should I start? Who's going to start?
Go ahead.
Please go ahead.
All right, I'm Kathleen Day. I'm a full-time lecturer at Johns Hopkins Carey Business School. And I have, unfortunately, I guess from some perspectives, an expertise in a history of financial crises. And we are in a financial crisis, of course, not one of our making. But one that nonetheless human activity has made worse, probably. So that's what I'll be speaking about. My colleagues are going to address healthcare in particular, but I will talk more generally, but with healthcare as a centerpiece of what's going on. So that's me.
Reuven, why don't you take
I'll go. I'm Reuven Pasternak, a Hopkins alum, and I'm a physician, anesthesiology and critical care by clinical background. Trained at Hopkins, was on the faculty there for 20 years in the School of Public Health and the School of Medicine. Did my work in risk factor analysis and program development, and then went on to a career in being a healthcare executive, running hospitals and healthcare systems. I stopped doing that, stepped down from that about a year ago, and was pressed into service when I was asked to come on as an interim advisor to the Department of Homeland Security to do program assessment and development to deal with the COVID crisis. And I've been in that position for 12 weeks on a one-year assignment. I'm going to be talking about the perspective of a healthcare system, which prior to COVID was a system that was notable for its decreasing resilience and its path that was leaving it less able to deal with issues such as this, which was skirting on the edge of distress and now found itself in a considerable period of distress, and look at some of the issues that are facing it, and also some of the solutions, positive solutions that are coming out of it to transform healthcare in the future.
All right, how about Professor Bai? I think you are, I can't hear you.
Modern life with Zoom.
Maybe you can, Jamie, can you unmute from your end?
She is not muted on my end, but why don't we, while we work on that, why don't we go to Doug Hoff?
Hello, everybody. My name is Doug Huff. Official title is Senior Associate at the School of Public Health. I'm an economist. I wanted to be an economist ever since I was a senior in high school, which was many, 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 many years ago. Was a sort of mainstream economist and then discovered behavioral economics. And one of the things I've been doing over the past 10 years or so is looking at the application of behavioral economics to health and healthcare. I've been at Hopkins for about 20 years, started at the predecessor school to the Carey Business School, where I ran the Hopkins Business of Medicine program, then moved over to the School of Public Health in 2013 in the Department of Health Policy and Management. And the interesting part is, sort of where I'm coming from on this is very similar to Dr. Pasternak, that economics emphasizes efficiency. And one of the things that both the US economy and the US healthcare system has been trying to do is emphasize efficiency. One of the big trade-offs of emphasizing efficiency is the lack of resilience. And we've been seeing that lack of resilience in pretty dramatic ways. And so I may be talking about that, as well as, who knows, whatever comes into my head.
Thank you. Professor Bai, can we hear you now?
Hi, can you hear me?
Yes,
Yep.
yay.
Great.
Yeah,
Sorry
go
about
ahead.
that. I'm Ji
No
Bai.
problem.
Yeah, I'm associate professor of accounting at Johns Hopkins Carey Business School. I'm also associate professor of health policy and management at the Bloomberg School of Public Health. My expertise is in healthcare financing and policy. So today I would love to talk about the COVID-19's impact on hospitals' future management in their revenue and expense. Thank you.
Hello, this is Ting Long Dai. I'm Associate Professor of Operations Management and Business Analytics at the Carey Business School. My expertise is mainly in healthcare operations, most recently healthcare supply chain management. Look at from global supply chain perspective, what can be done to make the medical supply more resilient. And I mean, resilience has been a hot keyword recently, but to look at what can be done to make the supply chain more resilient, to make it more transparent, because we know very little about this supply chain, and a lot of data are kept confidential. And so if we do not have transparency, there's very little we can do. And the other aspect I've been looking at is to look at the post-pandemic. In fact, actually it's ongoing. We actually have the problem now is look at the pent-up demand for elective surgery and also other services, to look at how to best deal with that surge and to serve patients, but also help clinicals and hospitals to manage the operations. I look forward to learning from my fellow panelists and also from the audience.
That's everybody. Lorraine, do you want to take it over?
Absolutely. So if each of the panelists would like to go ahead and tell us what your thoughts are on how COVID's changed not only the economy, but the healthcare arena, how it's affected providers, hospitals, the pharmaceutical industry. So why don't we go ahead and hear your thoughts?
Do we go in the same order, or how would you like us to?
You go free for all, see what everyone has to say, speak together, converse.
I'm going to be the generalist, and so should I start, because then my colleagues know much
Sure.
about the healthcare system.
Absolutely.
And what I am seeing is just the obvious, but I'll say it, the troubling and persistent fact that this is not going to be a V, meaning we were going to fall and then quickly get out of it. It's more like falling off a cliff and then going over some rolling hills in the valley. And one of the things that there's some troubling trends, which I'll just touch on, and of course they all impact healthcare, and I'm sure my colleagues can talk about these more, is unemployment now is about 8.4%. Now that's down from the 10% it was and the high at 14%, which was a high from the Great Recession of the 1930s. The 14% was a high. It's down from that, but there are some troubling trends. Number one, the jobs, even though jobs have gone up a little bit, it came down and it went up, and now we're starting to gain some. A higher percentage increasingly of jobs that are lost are permanent losses. They're not temporary closing and then with an expectation people will get them back. Secondly, young people are being disproportionately hurt. 16 to 29-year-olds make up 25% of the workforce, and but they're about 33% of those losing jobs. Non-whites are being impacted by unemployment at a higher rate. So more jobs are disappearing forever, more young people, and of course is causing the big question is the way in which this is raising the disparity in wealth. And oftentimes in economics, people talk about net income or your net worth, but also healthcare. I don't think that healthcare is adequately reflected in wealth gaps. And of course, the more, when you lose your job, many people lose their healthcare, that's going to impact the healthcare system. And that, of course, impacts so many things, including how hospitals, how they account for charity care. That alone, that's going to be a huge thing. How people are going to get prescription drugs, which my colleagues know more about. But the other troubling, so those are all trends that even though unemployment has gone down, there are many troubling trends in it. That's the big thing I would want to say. But that's the big one. I'll leave it at that and see if people want to add on to that. Oh, the other one I would want to say is that the government programs designed to try to help people economically. The problem is that I see, and this is a time-honored truth about people, when you get lots of money involved and you don't have a lot of oversight, you get a lot of fraud. And that's happening in the payroll protection program and in other venues. And that's troubling because it's a waste of money. It's not doing what it's supposed to do. It causes disrespect for the law. And it's not helping us get out of that rolling hill where we're not really getting an economic recovery. We're just kind of bumping along. So that's what I would say.
All right, feel free to go next.
I would love to add to Catherine's point. Before this pandemic, healthcare is always considered crisis-proof, right? No matter what depression or financial crisis we are going through, the healthcare industry's revenue is always there. The huge resilience, but this time is different. The revenue impact on hospitals, not because of COVID-19 per se, is because this non-COVID, but elective surgery and procedures, this huge drop in those services will bring a big drop in the hospital's revenue, in the volume, and that is unprecedented. So we have seen the hospitals experiencing huge financial challenges that they haven't experienced for many, many years. And that leads to all kinds of structural and strategic moves that try to blunt that impact. And I think those initiatives will have a pretty profound impact into the future.
What initiatives do you think would be helpful for hospitals to be successful and try to increase volume at this time?
Yeah, thank you. That's a great question. Hospitals trying very hard. For example, they are telling a positive message to the world that it's safe. We are doing all we can to make the infection rate as low as possible. But there's a limit what the hospital can do, right? And then they turn to their cost management. Eventually, the profit of a hospital is just the revenue minus expense, right? The revenue side, there's only number of things they can do, and the people, especially during the the peak of this pandemic, people are not going unless it's extremely emergent situation, right? So the revenue is being hit anyway. So hospitals try to take very aggressive measures to cut their cost. For example, we heard the furloughs, the pay cut, the layoff of clinicians, right? That is quite rare. And initially the public did not understand, but the hospitals try to stay afloat, and they are trying all they can to contract their total cost structure. And then we see many unfortunate news regarding how hospitals are trying very hard to cut their cost.
So, I'm sorry.
Oh, go ahead.
So when we talk
I was
about
gonna say-
having avoided crises, we've been skirting on the edge of a perfect storm for a while. And I think Douglas may have some of the same observations, so maybe we'll go in tandem here. Because we have found ourselves very often in situations where we are short on beds, short on supplies. We've been dealing with spot shortages for years now. We've been dealing with flu epidemics, not as severe as this, but flu epidemics stressing the resources of emergency rooms and hospital beds. And it was done with the idea, how lean can we run? And we got into how lean can we run. It was done without the resilience that both of us had mentioned. So for example, in terms of hospital beds per 100,000, we're the lowest in the OECD, admission rates lowest, length of stay shortest. So as much as healthcare costs here, there are ways in which we have pushed ourselves to the edge in that capacity. So what we need to do is build back that resilience. Where COVID called the question on this was that, in contrast to other situations that we face, whether natural disasters or flu, this has been a rolling crisis over months. It has been nationwide, it has been worldwide. So we have lost whatever cushion there was for other areas of the country to really lend help on a consistent basis, and with a worldwide shortage of other supplies. So it speaks to the need of how are we going to better manage our resources to be able to put some resiliency back into the system, in supply chain and in resources, while at the same time not doing so with the idea that there's an open checkbook to cover all costs. And I would hold there and see if Douglas would like to add on to that. Maybe we could see how we're in common there or not.
Yeah, I would. And actually, in a sense, I'd like to connect Kathleen's comments with Reuben's, in that what's going on in healthcare in terms of efficiency versus resilience is not a one-off. It has been happening throughout the entire U.S. economy. For publicly traded companies, they're focusing on what their quarterly results are. Their investors are pushing them to be as lean as possible. Then you've got private companies who are competing with the large publicly traded companies, and they're feeling the same kind of pressure. I used to work, before I was at Hopkins, I did consulting. I did consulting for about 15, 20 years, some of that with what is now PricewaterhouseCoopers. And of course, one of the things that good consultants do is go in and see, where can we cut costs, whether you're a for-profit organization or a not for-profit organization. What we can do to get that bottom line, as G had mentioned, as good as possible, and trying to find ways of reducing expenses. All very admirable things to do. And the application of things like Lean and Six Sigma, I think were well-intentioned and then succeeded in a lot of ways of trying to find how do we use resources efficiently. How do we use factories efficiently? How do we use labor efficiently? How do we use hospital beds efficiently? How do we use clinical staff efficiently? But as Dr. Pasternak and I have been saying, is that the downside of that is that you leave the organizations with not much slack. And as a result, when bad things happen, then they don't have enough organizational slack to be able to deal with it. And forms of resilience can come in in various ways. One is obviously, quote, excess, labor and space and beds and all that kind of stuff. But also taking this out of the context of just hospitals, the whole field of public health is designed for resilience. It's designed that if something bad happens, we have a system that will start to take care of it. And the issue of preventive maintenance in healthcare is very much of that kind of ilk. But at the same time, when state governments, when local governments are feeling strapped for cash, and there's a big demand for resources, then one of the things that they will look to is public health, because, well, we don't really need that. We don't need the STD clinics. We don't need the vaccinations because we got other problems we got to deal with. Yes, it's a big problem, but people aren't dying here. They're dying somewhere else, or we've got a political system that is demanding things that will generate real results. And one of the problems with public health is that if public health works, nobody notices it. D.A. Henderson had this wonderful quote that, I mean, he was the guy who led the eradication of smallpox. He said sort of longingly, you know, nobody ever comes up to me and thanks me because they didn't die of smallpox. So if public health works, nobody notices it. And if nobody notices it, then its salience is very low. And so when they're coming to, well, how should we spend our money? It's not immediately clear what the value of public health is. However, what we've seen in the past 6 months is what the real value of public health is as just one example of resilience. And my final comment on that for this part is if we looked at resilience as insurance, I mean, people buy auto insurance, they buy life insurance, they buy home insurance in case something bad happens. And no one would think of going without home insurance, even if your mortgage company didn't insist on it, because my gosh, if my house burns down, what am I going to do? But if we think of this whole area of resilience, not just public health, but quote, excess capacity as insurance, then let's not look at it as wasted if in fact we never use it. So and in that sense, it requires a different mindset in terms of how we allocate scarce resources among competing.
Can I jump in quickly just add on that? That's a point about science. And clearly this economic crisis is caused by a pandemic where you need science to remedy it. We're really not going to get out of it until we have a vaccine. One of the most troubling trends for me is this assault on the belief in science. And it is very troubling. And when you start having, especially when outside countries are trying to foment disagreement in the United States and fears about vaccines and science, it begins to erode public confidence, not only in science, but in seeing the need for it until people are stepping over bodies. And that it's troubling to me. I just wanted to add that.
What do you think we can do to make the public more comfortable?
I'm going to leave that to my colleagues. I just wanted to put that tail end where no one's going to come up to you and say, thank you for preventing me from getting smallpox. But I wonder but what I'm troubled by are people coming up to you saying, hey, don't give me that vaccine so I don't get smallpox. And both of those things are troubling. So I'm going to leave it to my colleagues to say, what could we do about it? It's a political landmine.
Do you think the vaccine is going to be to market very quickly? And if so, do you think the public should be concerned about any safety or efficacy?
I'm going to get it, but I leave it to my colleagues to talk who know more of the scientific end of it.
So there is reason to believe that a vaccine will, it's not a political statement, I'm just trying to stay with the science, because this process has been unique, would be an understatement for the way the vaccine development has done. So it can be an extraordinary success or not. The extraordinary success would be a vaccine available in December, early January, with a phase up of production such that it can cover the population within a couple of months for all who want it, with an initial distribution to those who are most in need, frontline workers in healthcare, at-risk elderly, and those who are confined. So it's possible. I can make a prediction. You're not getting inside information. You've read this in the newspaper. So I think that's possible. And I think the other point, Kathleen, that you make is the background. A consistent, honest message is the first step in getting the public trust and giving the public confidence that they're getting a straight story and that it's a consistent story. And yes, we're going to find our way out of this, but it's not an easy one. And so I think we have to find our way back into that groove. That's going to be a hard one to do.
Yeah, so I want to continue discussion about supply chain resilience. I just want to point out something really obvious here is that we can talk about on all the theory. We can blame lean, we can blame total production system. But there's something obvious here is that 80–90% of essential medical supply they pretty much come from foreign countries. And we don't have anything here. And we have a hollowed manufacturing sector. So that is a bigger problem here because we do not have domestic raw materials. We do not have enough machines, and we do not have machines that make those machines, right? But I think the most troubling aspect is that we do not have enough talents. We do not have enough engineers. And the number one most popular measure, and not at Hopkins though, is business, right? I'm a business school professor. I love business. But I do think that's a big problem here is that we do not have enough engineering professionals. We do not have enough people who know how to manage operations and people who know how to control quality. Those really basic stuff. And the reason 6 months into this pandemic, we still do not have enough domestic manufacturing capacity is not because we don't want to do it, really because we cannot. We don't have the capability, unfortunately. It's just impossible to build up that capacity in half a year. And because we don't have people here who can guide the process, we do not have those machines to build the machines that we need to do this. So it's a huge problem. So this really goes back to the notion of so-called industrial commerce, meaning that we need to have an ecosystem of engineering, has factories, but also talents, sort of like Silicon Valley. So the reason Silicon Valley is booming is not really because there's anything particularly special about geography of California. It's not about that. It's basically because this is one area that have a lot of talents, and this is where companies can find talents. This is where talents can find good employers to work for, right? So Silicon Valley is a great platform. So we need a platform for essential medical suppliers, and we don't have that platform. And in general, I think you would be very hard to find any business school professors who don't like global trade. I love global trade, but I do think we have a wrong notion about medical supply chains because you can think about the PPE, you can think about essential drugs as a service. Just like, if you live in a small town and you probably rarely have any fire accidents, but that does not mean that you shouldn't have a fire station. You should still have a fire station because fire, that's a service, it's not a product. So we have to think of manufacturing as a service in this particular context of public health. So unfortunately, there's no easy way for us to get out of this. In fact, if we have another pandemic 3 years, 5 years from now, we may end up having the exact same situation. Reason is because, as Professor Bay and I have been trying to look at some data, trying to understand the foreign dependence of US medical supply chain. We couldn't find any detailed data because most of the big players, bigger companies such as 3M, such as Honeywell, some of the audience members may work for these bigger companies. They keep such data as confidential, so they do not share about the capacity across different countries. And hospitals, they really know where their products come from. And we actually read that a lot of nursing homes, when they get shipments, they don't know what the shipments were from, what they were for, and it's a very, very opaque situation. If we cannot measure the foreign dependence of this industry, there's no way we can get out of this situation. Now, we have two presidential candidates. Both of them have promised to build 100% of essential medical supplies in the US. Actually, both of them have promised that. So this has become a bipartisan issue. But if we do not have any data, if we do not have transparency, I don't think it's going to happen. It's just going to become an empty promise. But in terms of impact on the job market, I actually thought that this actually presents opportunity, meaning that we should be expected to see more and more emphasis toward domestic supply chains. There should be, think about we are going to need more engineers, we need more production managers, we need more people who actively try to build up this supply chain instead of hollow out this manufacturing sector. So I think that's could be an area of opportunities.
Could I ask a question?
Sure.
Here, now I agree with you. Let me start with that. But let me be a devil's advocate. Let me pretend that I am Milton Friedman coming back from the dead. And I would, Milton Friedman, the University of Chicago, the markets always work their wondrous ways. If I were Milton Friedman or the editorial page of the Wall Street Journal, I would say the market is going to be the one who's going to determine the most efficient way of getting essential medical supplies produced and distributed in the U.S.
True. And the market is not going to pay for the losses of 200,000 people and plus, right? And and the other thing is that technically, yes, I'm all for free trade. I like most business school professors. However, what we see here is not free trade. What we see here is essentially corner solutions. Essentially, everything is made in a few countries, and we really need supplies in emergency. We don't have a supply. It's like if you do not have your own fire station, and when you have a fire, there's no way for you to expect the fire trucks to come from Ohio to Maryland. There's no way. It's not.
And I think Milton Friedman would agree with you. I think he would say, let's have a fire station. As if we come together as a community and decide to have a fire station, let's have it. And there is precedent for this. I personally, having covered, I don't want to say how many decades, how many crises where the auto industry is bailed out, and other industries too, but the auto industry you can see over and over again. And as someone who has some familiarity with the defense industry, I personally believe we bail out our auto industry to make sure that we have some capacity in manufacturing for defense. And I think we have to broaden that definition, as my colleagues here have said, to include we are good at manufacturing when we want to be, but we have let this go, and also toilet paper, as everyone knows, has become similarly so efficient that it can't ramp up. We need to think of national defense manufacturing to include more than just the capacity for cars and tanks and airplanes. We need to think of it for these things. Again, I will come back to the fact that I am very sad to see some of our premier scientific agencies like the CDC, which was stars in the world, the best in the world, being bandied about politically and having reputations unnecessarily sullied. So that it's distressing. And as part of that, I think we need to expand the ability of our manufacturing for defense purposes beyond big ticket items. I totally agree with you, but there is precedent to do that.
And the North American market is sufficiently large. It's not as though you're trying to promote an inherently inefficient manufacturing process.
Right.
So from our perspective, if you can develop that in North America, it doesn't have to be the US, whether Mexico or Canada, but as a shortened supply chain, to do that, that would make a major difference. I'd also want to add, we're talking about things we need to add. I think one of the things that has been encouraging has been the response that we've seen to some of the challenges. So that when we say we need to add resilience, we're also recognizing, as you say, Kathleen, we're in an economic crisis that's going to be with us for a while. And there's only so much money in the public pocketbook or even in industry, the private sector, to support developing resilience. So it's not all about adding more facilities, or that's part of it. It's how do we better use what we have? How do we add a capacity to be able to use some other facilities that don't usually take acute care patients? For example, placing patients in ambulatory surgery units and other units that addresses some of the issue. The use of telemedicine to move care out of the bricks and mortar and out of the face-to-face, that has been something which has had a difficult history getting going, yet it's one which has been known to have a great deal of promise that has gotten a major boost over the last several months, and successfully so. So we think that's something we can have an enduring opportunity to really take what we've learned from this and find there are new ways to provide care, and ways that we might not have done had there not been a crisis to push us along.
And Ruben, as you said, I want to interrupt you for 1 second, Ruben. As you had said, telemedicine has been a fantastic addition. And, we've been trying to push it forward for years and years, but we couldn't do it because it wasn't reimbursing. Now, do you think those reimbursements are going to be here to stay, or what do you think providers should be anticipating going forward?
I think it has taken hold, and I know from the government side, there's been a recognition that this is something that needs to be here to stay. So CMS is working with it. And a number of us are seeing what can be done to make this a sustained growth and development, so that it isn't here today and then pulled back tomorrow and we slide back to where we've been. It just has too much promise to go. So I think the reimbursement for it will change. It has in part, and it's already an area of significant interest in the commercial sector. So even what the government is not doing, the private sector is coming in to develop as well.
Yeah, if I may
in
add,
some sense, go ahead. No.
So thank you. So the rural health, especially for rural population, telehealth is extremely important. Last week, the White House released a rural action plan. We have substantial funding for rural health to adopt telemedicine. And also because of COVID, we relaxed the restriction on the non-physician clinicians practice rights and scope. That will also help the rural area and in general to deal with the shortage of physicians in the labor force to care for this aging population. Thank you.
Yeah. In some sense, the one good thing that's come out of this pandemic and this crisis is that telehealth has demonstrated proof of concept. Finally, I think providers and patients and payers have figured out, yeah, this not only can work, but it can be a net positive for the healthcare system. So I think this is going to be here forever.
Right, we have questions from the chat box.
Oh, do we lose it?
Oh. No.
Sure. Yeah, we'll go ahead and start with a few of them. From Deidre, she wanted to know, can you please provide guidance and resources on how physicians can navigate the system to get funding for private practices? Her office was closed for many months and she continues to have bills coming in, liability premiums, and surgical instruments.
If I may add on this point, yes, unfortunately, this whole allocation of funding, we have $300 billion from the CARES Act. The allocation, unfortunately, is in my opinion, regressive. So if you are large, you are politically powerful, connected, then you are more likely to get funding. And small providers are left out of this pie in many cases. So this is unfortunate, but in the future, I think this actually give independent providers opportunity to think about a new contracting model. For example, value-based care. right? During this crisis, the physicians who are contract based on per member per month are not experiencing severe financial damages. So there downside, there's upside for contracting based on value, but at least this pandemic tells us the upside of that contracting. And also this pandemic might motivate more physicians in independent practice to join large system, become employees. And that on itself reduce the physician's risk exposure. They are salary based, but on the other hand, reduce autonomy of physician and increase the market concentration provider, and eventually might drive up cost. So I do think this is a great question, and we have to, as a physician, we have to be innovative in thinking about how we can make a more sustainable revenue constraint.
And again,
so physicians moving from private practice to a hospital health system, do you think they have things to worry about as far as, surgical volume and, the potential of being laid off since there's not enough procedures happening now if they make that type of change?
Exactly. But on average, by joining a large system, the risk exposure becomes smaller. So the downside is being helped, right? You always be salaried, but the upper side is also be capped because you can't do the things as freely as you could before. So that is attractive to many physicians. And also by joining a big system, the price is higher, right? There's facility fee. For the same service, a large system can utilize their market power to charge a high price, and eventually the physician, in general, physician's income by joining a large system does not change to the downside. So that is attractive on surface, but in the long run there are a lot of problems. We have the corporatization of medicine, right? The physician lose control, eventually become employees and cogs in the wheel, and that has a profound negative impact on physicians' care quality and patients' experience.
That's why, again, I think it's tragic that the allocation of the funding that has been put together to help the smaller businesses, which individual physicians are, there's been too much fraud. It's gone to rich people. It's gone to connected people, as you say, and it's just tragic. It shouldn't be that way. But I think Milton Friedman would say, see, the government does a bad job at allocating, but I think the government could do a better job. And I think one of the things the United States has shown when we want to turn on a dime, when we want to get to the moon, if we want to develop a new weapon, not that that's necessarily a great thing in World War II, we want to do something quickly, we can do something large scale as a team, and we can do it well if people have the will and they don't politicize it. And so again, this doesn't help the doctor who asked this question to give this person resources of where to go. But again, I think it underscores the tragedy of how the money that has been doled out unfortunately, unequitably or inequitably, I guess is the word, and unfairly and not wisely in many cases.
So I think the common factor in there, Kathleen, is whether it's doling out money or allocating ventilators. If you do it in a state of chaos, you're not going to do it well.
Well,
absolutely.
We have proven, I mean, in World War II, that's something I know well as, I'm not old enough to have been there, but I did cover the national laboratories and so know in depth what went on, and it's breathtakingly encouraging. Or our launch to the moon, or when Apollo 13 had trouble with its ventilators on board, American engineers sat down, they were given the material that the astronauts had and said, figure it out, and they did it. We can do it. That old-fashioned Yankee know-how, we can do it. And I think that edge that we have had as Americans is being winnowed away with this assault on science. We have been the premier place, and now we are allowing, I think, foreign actors to come in and make us misjudge and suspect things that we shouldn't be suspicious of. So I think we could do it, but I think it's not been done well this time. And I don't think it's all, you can just say, oh, it's because it's chaotic. I think it's the leadership.
Absolutely. So we still have some more questions for you. So let's try to get to those before the session ends, and then we can answer a few more from your insights. So, and Keith says, we have read and seen examples of countries like South Korea learning from past epidemics, use lessons learned to have a positive response to COVID-19. What lesson should the U.S. healthcare industry learn from this moving forward?
Well, I want to say something really small point here is that make sure we're not learning the wrong lessons. And for example, look at 2009 H1N1. During that pandemic, U.S. manufacturers actually built a lot of capacity for PPE. But unfortunately, by the time the capacity was expanded, the hospitals they didn't need that much inventory. So what did they do? Eventually, they sold all the machines to Chinese factories. So I think that was a wrong lesson to learn from H1N1, which was that you don't want to build the domestic capacity. But to be fair to the Obama administration, they did learn a lot from H1N1 pandemic. So this is why we can vaccine manufacturing. A lot of work after H1N1 pandemic. But in the private, I thought there was coordination between healthcare providers and the patients. So one aspect we want to look at, make sure certain things are learning the wrong lessons, and the right lessons.
Thank you. Okay, our next question. In large-scale emergencies like this, corporations will often privatize the gains and leave the government to subsidize losses. We have already seen evidence of this playing out with the Paycheck Protection Program. From a healthcare policy perspective, what areas should we most be cognizant of for this sort of institutional leakage that can cause recovery to take longer?
Fraud. Fraud is bad. It's wasteful. That's all. That's my 2 cents. We need.
Do you have any advice to the attendees on what can be done to prevent this or help alleviate the situation?
I think accountability for when that happens and attention to when it happens, take the money back when it does and get the money back to where it's supposed to be doing good. I mean, that seems basic.
But what I see over and over again in financial crises, recovering money afterwards is always more expensive. You need policing up front. You can't just say, here's the money and run, which is what's happened. There should have been a little more thought in policing. When you have money and people, it's not rocket science that you're going to have people take advantage if there isn't policing. You need some policing.
Well, the other...
Sorry,
go ahead, please.
Sorry. And we published an article several weeks ago on Journal of General Medicine looking at the lobbying expenditure during first quarter of 2020. And not surprisingly, healthcare became the highest, the industry with the highest growth in the lobbying expenditure. And the 3 largest expenders in the healthcare sector are pharma, which is a lobbying group for pharmaceutical manufacturers, and then American Medical Association, which is the trade organization for physicians, and then the American Hospital Association, trade organization for hospitals. So you can see whenever there is a big pot of money to be allocated by government, right? These powerful organizations are trying very hard to help get a big part of the pie. Beyond the associations, we have big companies in every industry, including those the air ambulance industry. They're all trying to get their share from this big pie. So we have to be very vigilant when it comes to spill out, like Catherine said. If we have money, we have people, then and then there's no market force, then we are very likely to have a regressive system that hurts the powerless people, the powerless parties.
And it's not at all surprising that politics played a large part and lobbying played a large part on this. now I may be sounding like a one-trick pony, but I'm going to come back to resilience, but in the sense of infrastructure. I mean, in deference sort of to the Treasury Department, how long did they have to build the structure to distribute $1 trillion? I mean, I'm forgetting the date, so I'm not going to say. They probably had about a month. I mean, what organization is going to be able to figure out how to allocate $1 trillion efficiently?
Yeah,
and
but
part of the reason is that they weren't ready for it.
And they were spending so much time dismantling regulations rather than thinking about how to have sensible, common sense regulation that polices and make sure taxpayer money isn't wasted. It's just unconscionable to waste taxpayer money. I don't know about you, but I'm sick of it.
Well, and nobody's in favor of fraud except for the fraudsters.
I don't know. I think that my colleague made a point that a lot of this money went to friends of people in charge, and that's not, that's crony capitalism.
Well, it's crony capitalism, yes.
You can also suggest that easily at that. It's pretty stinks, and you can smell it pretty easily.
Yeah.
I want to say something. Oh, sorry for interrupting you.
No, go ahead.
But I want to build on your point is that we need better infrastructure, except I want to say this about information infrastructure, because we're the most advanced country in the world in terms of information systems. But if you look at the PPP application system, I think it's not the most advanced system you can imagine, right? And people look at the database, look at the way people spell Philadelphia. There are like 75 or 72 different ways of spelling the city name. So I don't think that's ideal. And we have Google, we have Facebook, we have Oracle, we have the best people in the world, but they're not being deployed for building such a infrastructure. If we get the best people, they can build the system in 2 hours, better than what they're kind of doing within 2 weeks. But they're not being used because this contracting process does not really support choosing the best talent to do a good job. So that's very obvious, but I think if you don't have a good system to start with, the system is bound to suffer a lot of fraud.
And let me tell you what I'm really worried about. That I'm not worried that we're not going to get a vaccine. What I'm worried about is once we get the vaccine, how are we going to distribute it? And I mean, I've seen all sorts of op-eds. I've seen some of my colleagues at the School of Public Health and at the Berman Institute of Ethics opine on what the allocation system is. But I'm really worried about what's actually going to happen and who's going to be the first and the second and the last recipients of that vaccine. And now I'm not going to channel Milton Friedman because the market system is not going to be the appropriate approach. But I'm really not certain that that we as a society know how that allocation system should work.
Well, you look at H1N1 vaccine allocation. I thought they did a very good job. I mean, there was some supply shortage, some delay, but in terms of allocation in terms of distribution, I thought they did a great job of allocating H1N1 vaccines. But what they did was the opposite of Friedman, which was a centralized allocation system. So you allocate in proportion to each state's population, and you have a central distributor. And you distribute, you have an allocation system, and you decide how many doses each site would be receiving. So that's very centralized, very well coordinated. So when I explained the system to a journalist basically in Britain, and I told her this is something very, very atypical, very strange to US healthcare system. She was like, why is it strange? It is strange because we got used to this decentralized system. Everything is done through market mechanism. But I'm just saying that if you look at 2009 and 2010, it was pretty orderly allocation process.
The National Academy of Medicine has provided a guideline that the Centers for Disease Control, which is responsible for drawing up what the distribution process would be, at least initially with supplies, has done it with several tiers. And the first tier was people, caregivers, first responders, and people at greatest risk. Now, you can debate whether that's how it should go. Some people feel teachers should be in that tranche also. But to those who are most at risk of the complications and to those who are most engaged with taking direct care or protecting people, and then on to those who support them. How it works, I think, remains to be seen, because it gets produced and it gets delivered, and at some point in time in that production or supply chain, there's discretion that's involved, and people start asking for favors, and can you maintain the integrity of that process when the vaccines actually start coming? The other things, just to add to it, is to be sure, do we have enough needles, syringes, and vials to put the vaccine in, and refrigerated transport to get there? So these are all the factors that come into play in that supply chain as well. But it will be a complex venture.
Thank you so much. We have time for one more question for the group. From an anonymous attendee: in order to save money prior to the pandemic, I have observed that some healthcare organizations imported their nursing staff from overseas in lieu of hiring local US-based staff. Now with the pandemic, travel restrictions have impacted both travel to the US and abroad. Hospitals now want more local staff. What can be done to encourage American hospitals to employ US-based staff, pay them fair salaries? Dr. Pasternak may have witnessed this importing of nursing staff during his years at Northern Virginia. Why can't a hospital, which is not for profit, cut salaries of their top employees and keep it for nursing staff?
Good question. Actually, that's the first I've heard about foreign nurses being brought in to take the place of American nurses. I know American nurses have been stretched to the breaking point in terms of what they've had to do. So any help that they could get, but oftentimes it's been nurses coming in from non-affected areas to lend a hand. So I'm not familiar with that idea. I would certainly support nursing staff getting the support and supplement that they need, and also being sure that we have them there in the future.
Thank you. Does anyone have any other points to add before we wrap up for this evening?
I think nurses have been in short supply is one thing that I understand. I understand that from my students, many of whom have been in nursing, is that nurses are in short supply.
Yeah.
And I believe that is an economically driven decision. Like, although we need nurses, but at the same time, the hospitals need to cut costs in order to be financially viable. So that leads to a very counterintuitive decision in terms of layoff and pay cut for nurses. And even in this case, importing nurses to cut costs.
Yep.
Absolutely. So thank you so much, everybody, for joining us tonight. Our panelists were wonderful. If you have any questions or would like to get in touch with anybody, we'll be sending an email out with that information, and you can reach out to us. So I'm going to hand this back over to Jamie.
Thank you so much. Unfortunately, we're out of time, but we'd love to thank our speakers for their time and their talent, and our wonderful moderator, Lorraine. We'd also like to thank you for joining us for tonight's webinar. A follow-up email, as Lorraine said, will be shared with you following the webinar, and that'll include a recording of the program along with a list of resources and our event schedule. We hope you will join us at a future webinar. Thank you so much. Have a lovely evening. Stay safe, and thank you for your time.
Thank you.
Thank you.
Thank you.